A very good morning, everyone, and welcome to the second day of SIMCON 2023, the annual 7th academic sessions of Sri Lanka College of Internal Medicine. On behalf of the organizing committee, I would like to thank you all for coming today. And we are delighted to have such a large turnout of internal medicine physicians, trainees, and other healthcare professionals. Today's program is packed with exciting and informative sessions covering a wide range of topics in internal medicine. We have invited some of the leading experts in the field to share their knowledge and insights. To start the first segment of today's program, I would like to invite Dr. Rakita Higgoda to chair and conduct the sessions. Thank you.
Good morning, everyone. To start the second day of SIMCON 2023, we have the How to Pass MD segment, part 2, the Viva component. Today, our resource personnel are Professor Shamali Abayagunawardene, consultant physician and professor in medicine from University of Peradeniya, and Professor Shaluka Jayamanna, consultant physician and professor in medicine from University of Kelaniya. We'll have 4 mock Viva sessions with 4 registrars who have kindly volunteered to participate, which will be followed by a brief discussion about the MD Viva segment in the MD examination. I would like to invite Professor Shamali Abayagunawardene to start with the mock Viva sessions, and the first candidate will be Dr. Jayamanna to start off with the emergency Viva session. Over to you, madam.
Good morning to you all. We have to change the order of today's mock Viva session because due to unavoidable reason, Prof. Shaluka is getting late. So we thought we'll start with emergency Viva and then discuss 4 scenarios. Then after that, we will give an introduction later on. Okay? So,
I am Jayamanna.
So this is your candidate copy. Read the first one only, right? Can you project the candidate copy? So although this is a mock exam, I might prompt the candidate for answers, or even I might give a small feedback with the interest of time because I may not get another chance to give a feedback. Can you project the scenario?
Okay, madam.
Right, Jayamanna. Now, can you tell me what are the clinical problems this patient is having?
So, madam, this patient is a 65-year-old female who's in psychiatric ward and having multiple medical problems for which she was on follow-up. Now admitted with a history of altered level of consciousness and referring to us because of patients having drowsiness, low BP, as well as low sodium. So problems in this patient, for the first thing is the acute problem. One thing is the low GCS with features of shock. That's the first problem. And having background history of background medical history, which is we are not much aware. And then other problem is she's having features of cellulitis, as well as she's having severe hyponatremia.
Is it severe hyponatremia?
Sodium 120, so it's less than 125 minimum, so it's severe hyponatremia, and that's symptomatic as well.
Okay. So what are the causes of drowsiness in this patient?
This patient, madam, I think I have many differential diagnoses. One thing is she had a history of left side low limb cellulitis for 3 days back. For now, it may be cellulitis leading to septicemia, now coming with septic shock, and probably complicated with encephalitis or delirium. That can cause this kind of picture, but the abnormal thing here is she doesn't have the features of shock like tachycardia in the presence of hypo or the shock. And the other problem is she was on long-term lithium, so lithium toxicity also another possible differential diagnosis, because long-term lithium toxicity can give rise to neurological problems rather than the GI problem, which is occurs in the acute setting. So that's the second thing. Another thing I would like to consider here, the endocrine causes for the shock. Like she was on long-term lithium, probably lithium-induced hypothyroidism, now coming with myxedema coma is another possible differential diagnosis in the presence of this shock, bradycardia, as well as low sodium.
Okay. So in addition, she's having symptomatic hyponatremia
Symptomatic
as well.
hyponatremia.
Right. Okay. So what are the other clinical, if you think of myxedema coma, what are the other clinical signs you would look?
In this patient, the general appearance, patient might be having the features of hypothyroidism. That, one thing is a brittle hair, loss of lateral eyelashes, then the coarse skin, the peritibial myxedema, as well as in the examination you could find the
Peritibial myxedema.
mainly the edema.
Right.
Then because of the heart failure and all, and they can get the slow relaxing reflexes.
Anything in the abdomen?
And then the abdominal, the main feature is the slowness of the organ function, so they can reduce bowel sounds. Or ileus can be.
Features of ileus.
Ileus
And
can
in the heart?
you can get the bradycardia and peripheral coldness, or the hypothermia is another feature.
Right. Can you tell me what are the initial investigations you would do in this patient?
In this patient, basically, I will start with the acute management, like basic investigation of blood capillary blood sugar levels. Then I would like to do the ABG, because patient is having hypoventilation features. So I want to look for the possible type 2 respiratory failure as well as lactic acidosis in the presence of cellulitis, and I am suspecting septic shock. Another investigation, of course, I will send the septic screening, then the full blood count, inflammatory markers, those things, as well as I want to send in this patient the TSH as well as the random cortisol levels, and lithium levels is available, and CPK as well, because he's having psychiatric background. Maybe she's now present in neuroleptic malignancy syndrome. And urine toxicology screen also, if available, I would send. Another thing is she's having bradycardia, so ECG is a must in this patient.
Right. So this is the ECG. It's the next page. Can you comment on the ECG while looking at it?
So ECG is in sinus rhythm, so PR interval is static, and axis is normal, and the marked feature here is the patient has low voltage complexes, limb leads as well as a precordial leads.
Okay.
And I doubt whether in the lead 2 there's a features of Osborne wave, and I want to know the patient temperature as well before interpreting the ECG, and there were no other features of any ischemic changes.
So the
significant
obvious features are bradycardia and small complexes.
Small complexes.
What are the other features they can get in the ECG?
In hypothyroidism. So other things, in the hypothyroidism, it can complicate with the pericardial effusion. In that case, you can get the electrical alternance.
With the interest of time, I would say they can get prolonged QT interval as well.
Yeah.
Right, okay. Can you briefly outline the management, supportive as well as the specific?
Yeah. Here, the management is a medical emergency, so emergency attending the patient is important. The standard ABCD approach would be the way I would manage this patient, airway, secretion.
After airway breathing.
And then I will start a specific management. Here I would initially suspect the septic and septic shock. So I will follow the survival sepsis guideline. I will take the septic screening and I will start on broad spectrum antibiotic, probably with the CNS cover. Ceftriaxone 2 gram BD would be an option here. And then I will start as I am suspecting myxedema coma. After taking TSH and cortisol, I will start the specific management for the myxedema coma. So here I will give the IV hydrocortisone prior to initiation of the thyroxine. IV hydrocortisone 100 milligram 8 hourly, followed by, if available, IV levothyroxine 200 to 400 stat and 100.
Why you give hydrocortisone?
Hydrocortisone, there are many reasons. One thing, hypothyroidism can associate with autoimmune adrenal failure. So there can be associated Addison's
Primary
disease.
hypothyroidism.
Yes,
Primary
hypothyroidism. And then other thing is when we are giving the thyroxine, there can be, because of the metabolic rate will be coming back to normal, so there can be adrenal insufficiency with the accelerated metabolic rate. And other things, when we are giving the thyroxine, the metabolism of cortisol will be increased, so relative adrenal insufficiency can be there. Those are the reasons why I'm giving.
Any problem with ACTH?
The other things, hypothyroidism can cause blunted ACTH secretion. In that case, there can be
okay.
other.
So if there's having
central
subclinical hypoadrenalism with accelerated metabolism, they can get acute adrenal insufficiency. Right, okay. So what are the doses of thyroxine?
Here, what the guidelines says is you have to start with IV levothyroxine, 200 to 400 micrograms. That's a stat dose, followed by 100 to 200 daily.
Yeah, if IV available, not available.
In that case, the only option would be the oral, or here I will put NG and then I will start the NG. So here the dose would be, in Sri Lankan guidelines, 500 micrograms stat, followed by the maintenance dose.
So how do you, yeah, the time is up, right? Okay. So how do you mark yourself? If you reflect yourself?
So I think it's a complicated case, but here there are, my main worry is there are two sides of this. One's a hyponatremia and other things, the shock. So managing two in together, it's a challenge for me actually.
Right, okay. So actually in the emergency Viva, we do not give very complicated cases. What we give is common cases you see in day-to-day practice, right? So generally what we expect is you need to identify the problems, and then you need to plan the initial management as well as the specific management. And then it's good that if you know the pathophysiological basis of the management you offer to the patient. Right? So those are the things we expect. If I comment on your performance, Dimantha, actually it's good. He picked up all the problems, so the only thing I noticed is you are not very specific, right? So it's only 10 minutes for the Viva, so we have about 10 questions, right? So it's good if you can answer all those 10 questions. So if you waste a lot of time on one question, you may not go to the end, right? So try to be more specific and do more Viva scenarios. So I will give a clear pass. What about you?
Yeah, I would give a little more because I thought he was answering almost all the questions. So therefore, I think he will get a good pass, definitely.
Thank you, sir. Thank you.
I now invite Dr. Vishwa for the Viva on ethics.
Next slide. Hi, good morning.
Good morning.
Yeah. So you have been given a scenario. You have some 3 minutes, 2 minutes to read it. Or shall I read it for you? Yeah. You are the medical registrar on call. You have 2 patients in the ICU. There is a 62-year-old man with acute confusional state and fever and focal slow wave pattern in the EEG. And the neurologist has suggested a contrast MRI. And there is a 60-year-old female with reduced level of consciousness with inconclusive evidence of a cerebral infarction, and the radiologist has suggested MRI. You have only one MRI slot, and you have to decide whom to send. The female patient's daughter is your batchmate and requests your assistance to proceed with the MRI. Next slide. Next slide, please. Yeah. So my first question is, what facts will you consider in prioritizing the MRI? Here.
Yes, I am Dr. Vishwa. So in a resource poor setting, especially in a country like Sri Lanka, we have to make many difficult decisions, and I have to acknowledge that this is going to be a difficult decision. But in my best clinical judgment, I think that it is going to be the 60-year-old gentleman who will benefit from the MRI at this venture. The reasons being is, one thing is, we do have a tentative diagnosis for the lady. She is having a probable stroke. I will like to clinically correlate with physical examination and history also, but there is a suspicion of an infarction in that lady. With the gentleman, we do not have a proper clear-cut diagnosis. And his clinical situation seems to be, he seems to be a bit more ill. He's having fever, he's not doing well. So that is one reason I would consider the MRI for the gentleman. The other thing is how would it change the management. With the lady, she's having infarction. I can start the secondary prevention then and there itself. For the gentleman, apart from empirical therapy, I do not have a specific etiology or diagnosis for him to treat him with. And early treatment for him might be very important in terms of his prognosis. So the sooner I come to a diagnosis, the better. So in terms of the management also, I would consider the MRI to be more important for the gentleman than to the lady.
Yes. Yeah. So you are actually considering medical facts. Shall we move on to the next slide, please? So there's a difficult situation now. You have to communicate your decision to your batchmate who is putting peer pressure at this stage. How do you communicate that to him?
Yes, sir. So again, I have to acknowledge it's going to be a difficult conversation, but a very important one. I will have to do it with an approach of compassion and empathy. So first and foremost, I'd like to make sure that we can speak in a comfortable environment for her. And second of all, I had to remember that she might be a doctor, but first and foremost, she is a daughter of a father and a mother. So I would like, if she would wish to have somebody with her, maybe her father, who's also the wife, the husband of the patient, I would definitely accommodate that as well. So then I would have to start the conversation that we believe that I have to be frank and open and honest with her. I will tell her her mother's current situation, what our likely diagnosis is, and that the radiologist has suggested an MRI for further clarification probably. However, I would mention our limited resources. Hopefully she will also be able to empathize with that situation, but she does not have to. And I would say that we also have another patient who's also acutely ill, who we do not have a diagnosis for. And I would say that after discussion with my team, with my fellow colleagues and the decision makers, we have decided to, at this moment, offer the MRI for the gentleman, because we believe that will help him first. Of course, I would also acknowledge her feelings, how she feels about this, and I would try to offer her alternatives. For example, the infarctions, sometimes if CT is a more readily available imaging modality. So if I can repeat the CT in 24 hours, maybe I can come up to a more clear-cut diagnosis also. So I can offer that alternative to her.
Yeah, she may agree, she may not agree.
Yes.
Anyway, what ethical principles will guide your decision?
I think the first ethical principle here would be justice, which is fair and equitable and appropriate treatment for all. So in my clinical judgment, and of course I'll try to reach a consensus with my team as well, it is the gentleman who requires the MRI. But if I give that MRI slot to my batchmate's daughter, I am not being just to the gentleman who most likely needs it more. So justice would be my guiding principle in this delicate situation. Of course, I would also like to do no harm, beneficence to the patient. So acting on the best interests of the gentleman, I would like to also arrange the MRI for him. So those would be my ethical guiding principles in this particular situation.
Yeah. Now, yeah, okay. The problem is that you find it very difficult to convince your friend or batchmate, and then she is not still happy, and she writes bad about you on social media. How would you handle that situation?
Yes, that is unfortunate, of course. We always consider the opinion of our peers to be important, but that is a personal problem for me. I would, this is not my personal, I have to acknowledge that the resources are not my personal purview. It is public purview. I have to consider all patients equally. So I would, of course, I would speak privately with my batchmate and try to convince her that I'm just acting on the best interests of everyone involved. It was nothing personal. If she accepts it or not is up to her. But I will not let it affect my professional judgment.
Yeah. Okay, we have concluded. I think thank you. You were having eye-to-eye contact with me, and you were trying to explain your views. On the first instance, where you had to take a decision. So if you have taken the wrong decision, of course you failed. So you took the correct decision, but you should have given not more than medical, actually, what are the ethical grounds that will guide you because you are not rather more checking your clinical knowledge. So you should have said that there are two situations where a patient will be more benefited in this situation. Actually, it's not correct. Like maybe both patients should require it clinically, but then you have to, in a resource-poor setting, you have to select the patient who will benefit more. So you try to explain that. I'm very happy that you explained most of the things that will guide your decision. And when it comes to handling a difficult relative, a very difficult relative, there are few things you do. You usually try not to talk to her alone. You'll try to talk with the family, because there are other family members that might convince her to change her mind when you talk. And then the second thing is you would involve a colleague of you, usually, especially senior colleague, rather than handling that situation. Then you show that there is consensus in the team regarding the decision, so that the patient relations can understand. So I think that is also important. And when it comes to ethical principles, you explained fairly okay. I'm happy. Handling aggressive patient towards you who try to do bad for you, affect your reputation. That's of course not in ethics. I just put that question just to make it a little difficult. But we will not ask. We really will ask a question like that. Anyway, overall your performance is okay. I mean, you can realize is that in ethics we can ask varying questions. The range is not small; it's a very wide range. And nowadays, because there are 2 other stations where your communication skills are checked, we look at how you handle the situation. So there is, few mocks will help you to get in touch with the situation, but of course you can't have all the clinical situations be prepared. So you should be able to change, but use the same principles that apply. Right.
Thank you. Shall we move on to the next scenario?
Thank you, Dr. Vishwa. Now I would like to invite Dr. Subani for the Viva on current medical literature.
Good morning, Subani.
Good morning, madam.
You have about 1 minute to go through the scenario. What are the observations, your observation regarding these patients' problems?
So this is a 50-year-old male who has a background of DM, hypertension, and dyslipidemia. And going through his values, his blood pressure is reasonably controlled, but he has a high HbA1c and LDL of 70. So considering a risk scoring, since he does not have atherosclerotic cardiovascular disease, we will need about moderate to high intensity lipid reduction, so his target seems to be reasonably all right. And coming into his creatinine, it's 1.3 with a GFR of 60, so there's a mild rise in the creatinine, and USCR is high, so it's 838. So problems are reasonable, high HbA1c with mildly rising creatinine and a high USCR, and and he's currently on this glycoside, metformin, atorvastatin, ramipril, and diltiazem. So ramipril is the maximum dose that he's supposed to be on, and atorvastatin, considering his lipid targets, seem reasonable enough. So my next goal will be in trying to modify, if possible, the HbA1c goals, the creatinine, as well as the USCR, if possible.
Right. In addition, the patient has got retinopathy as well.
Yeah.
Right, okay. So what is his cardiovascular risk?
Considering that he has this background of DM, hypertension, and dyslipidemia, so I would like to put a formal scoring system here. And there are multiple scoring systems, like you have the Q risk.
If you look at these values?
Looking at these values, so he has a moderate to high risk, but not very high risk, because there is no significant atherosclerotic events that have occurred in his history so far, at least.
Any features that push him towards high risk?
The USCR does push him into that, the USCR value and the rising creatinine and the HbA1c values, perhaps.
As well as reduced GFR, isn't it? Yeah. So what will be your next therapeutic option?
So considering the current recommendations, usually we will try to go for a maximum ACE dose, which has also already been started in this patient. The next type option would be to try to incorporate, if possible, an SGLT2 inhibitor to the armamentarium that is available to these patients, if we can afford it and if it's available. So that becomes my next option.
Okay. Can you just outline the benefit of adding SGLT2 inhibitor?
So considering this patient, looking at the renal protection angle, currently SGLT2 inhibitors have been very well known to improve the renal protection over the long term by reducing EGFR that occurs. It can also reduce the UACR, it can reduce the urine albumin because it has now been postulated to reduce the intraglomerular hypertension. So if we can reduce the pressure, we can reduce the hyperfiltration, which in turn can give rise to a reduction in the microalbuminuria. Other than that, it has the mechanism of action is to try to reduce the sodium absorption, so by which there's a significant glycosuria, which can also contribute towards reductions in the HbA1c as well. Other than that, there is also a significant cardiovascular benefit that we can see in these patients.
Right, okay. What are the trials that confirm renal protection with SGLT2 inhibitors? Can you name them?
With renal protection as a primary endpoint, we are looking at trials like Credence as well as DAPA-CKD, and the most recent being the EMPA kidney, with the kidneys by itself as a focus, but then the other trials have also looked at secondary endpoints with renal outcomes as secondary endpoints, such as the EMPA-REG trials, where they have even Canvas and TIMI, they have looked at renal protection as a secondary endpoint, but the primary endpoint have been these three trials.
Right. So if you take all these renal protection trials, can you just comment on the recommendations or the results?
The first trial that looked at renal protection was the Credence trial.
Now, if you take everything together, what type of patients?
So in terms of what they looked at, like say again, the three different trials looked at different types of patients. The first one was mainly diabetic patients, but as they moved on into the second and third trials, they looked at both diabetic and non-diabetic patients. And in terms of the targets,
Credence is only diabetes.
Only diabetic patients, and then DAPA-CKD and EMPA kidney incorporated other patients with low GFRs as well as high UACR, and also. When you look at the GFR targets, the initial trials probably looked at a GFR from up to 130, but now the newer trials are incorporating 25 eGFR of 25, even 20, being the last trial had incorporated patients up to UACR of eGFR of up to 20 in those particular trials.
Right, okay. So the outcome?
Renal outcome, they have shown that there is a significant reduction of eGFR over time. The rate of progression as well as the UACR has also significantly improved in these patients.
Right, so if you go through the next page.
So after 6 months, so we have achieved our HbA1c of around 6.6, which is reasonable for this patient. But we seem to be failing in terms of the UACR, so we can perhaps add something else to perhaps optimize the
so what would be your next therapeutic option?
So currently the next drug that has come into the play is non-steroidal mineralocorticoid antagonist, particularly drugs like
So what about steroidal MRAs?
Steroidal MRAs have not been specifically
So what are the
tested.
examples?
Steroidal ones would usually be the drugs that we know, usually the spironolactone and the eplerenone, which are the drugs that we know, but they have been tested, but there is no significant benefit as such when you look at UACR and eGFR in those patients, but they have been shown to have cardiovascular benefits and in cardiovascular trials.
Right, okay. So what are the other types of MRAs?
So we talk about the non-steroidal ones. We have now Finrenone, which has come into the market. So
it's Finrenone, right? Okay.
And there's one other drug which I can't recall. There's I think one more. Finrenone is I can remember.
Okay. So what's the evidence?
So the evidence comes out of, again, two trials. One is the Fidelity and the Figaro, and then there is a Fidelity, which looked at a meta-analysis, which has shown that there is a significant reduction of the urine albumin, but they also looked at other mechanisms, particularly the reduction in overall inflammation, fibrosis in the kidney, so that they can reduce, which can overall contribute towards reducing the oxidative stress in the kidneys, which in turn, over the long term, probably has a like anti-inflammatory and immunomodulatory effect as well, and has been shown to reduce USCR over the long term.
Okay, so Fidelio DKD trial, and there's another small trial.
Figaro.
Right, okay. So what are the differences? What type of patients they have selected?
Again, their main target was, again, the urine albumin was their main concern, but the targets...
It's the GFR, isn't it?
Oh, sorry.
In the Fidelio, it's low GFR.
Low GFR.
The other one is patients with high GFR.
High GFR.
In both groups.
It was the USCR. They had gone down to an almost normal USCR in some of the
Right.
trials, and very high USCR in the other trial.
Right, okay. Right, thank you. Time is up. So in this current literature Viva, we do not go into one trial and discuss that trial. So currently what we do is we take a case scenario and we discuss the case scenario using the current literature, right? So that's what we did today. So it was excellent, Subhani. So nothing to correct, I suppose. But only problem is, I would like if you have eye contact with me, and if you reduce your speed of talking, because certain things I could not follow, right? So those are the only problems I had. But the knowledge and how you apply your knowledge to the scenario is very good. Thank you very much.
Yeah, certainly. Excellent performance. But I think you were prepared and probably you read around the area and came, hopefully. But when you come to the Viva, it's slightly different situation, because where you can be asked any. So I think you should look at the landmark areas where practically important. So because we will not ask. So because so many trials come every year, you can't read all and memorize all in an exam like this. So basically the landmark changes is what we will concentrate. Okay, thank you.
And one more thing, if you are familiar with the Sri Lankan trials which are related to that area, so that also will be beneficial. The big ones, right? Okay, thank you.
Thank you, Dr. Subhani. Dr. Chandana will be here now for the last Viva on chronic disease management.
Yeah, hopefully you can read that.
Yes.
Okay. Yeah, okay.
Yes.
Very, very simple scenario where it's a very common problem. Yeah. So my first question is on that. What features in the history is important?
Yes, sir. This 56-year-old gentleman, a farmer, coming with back pain for 3 months duration, which is not responding to treatment. So the history, I want to know about this onset of the pain first, whether it was of insidious onset or there was a preceding event, like a trauma or fall, like a traumatic event. And then also I want to know, since then, how it was up to now, like it was progressively worsening or it is static up to now. And also I want to know, the important thing is whether this pain is related to movements or any other there are any other aggravating or relieving factors of the pain as well. And then also I want to know this pain is purely the back pain or whether there was associated with associated lower limb pain as well, whether there are any motor symptoms or sensory symptoms also. I want to know, important in the history. And also I want to know whether there is any bladder or bowel symptoms. Now it says there are patient has no other symptoms, but I want to ask that also. And also I want to know that patient has associated this loss of weight, loss of appetite. And also in the background history, I want to know whether patient past history, whether patient was treated for some infection like tuberculosis in the past, and also patient had a malignancy in the past, and also patient's exposure to possible tuberculosis patient. And also it's a farmer, so I want to know whether it is cattle farming and what sort of work he's doing.
Well, he complains of a persistent back pain, and he has numbness of his feet also. Okay.
Yes.
So my next question. So what in the examination? What are the findings you would look for? I think you elaborated that even in the history.
Yes.
Yeah.
Now, as the patient complained of lower limb numbness, I actually want to do a detailed lower limb neurological examination as well. First, in the general examination, I look basically patient with the pale and whether there are lymphadenopathy, and also especially I look at the back also, sir, whether there are any deformities obvious and any tender points, any malalignment of the spine as well. In the lower limb neurological examination, I look whether there is any power reduction of power, and whether that numbness is associated with some sensory impairment, whether that I can get localized to the lesion like root lesion or something like that. And also I look whether there are any perineal numbness also whether this patient has.
Yeah, you could not localize, but he complains of numbness of feet, especially on walking. Okay, so what are the features in the clinical assessment that would prompt you to go for further investigations?
Yes.
It's a common problem. Yeah.
Yes. Now this patient already has pain for 3 months duration, for severe pain for 3 months duration without responding to treatment. So that itself prompted me to go for further investigation for this patient. And also if this patient has associated loss of appetite, loss of weight, and bowel symptoms, then also I have to promptly go for further investigation of this patient to find out the cause, because that could be some serious problem.
Can you list some findings that will make you to go for further investigations?
Yes, sir. One thing is if the patient has saddle anesthesia, which is suggestive of a Koda-Equina syndrome, so I have to neurological deficits. And also if that is associated with severe loss of appetite, loss of weight like symptoms, so that is also I have to go, like it could be a malignancy. And also some other like infections causing cord compressions and with the collapse the vertebrae, and so those things also I would look in my examination to find out for etiology.
So what are generally called as red flag signs.
Red flag signs. And also if the patient's worsening neurological symptoms, also it's red flag signs.
Okay. So what is your plan of investigation for this?
Investigation first is to find out the cause for this pain, sir. So I would start with the blood investigation first, where I will do a full blood count where I look for cytopenias and also inflammatory markers, especially to look whether any high ESR or CRP. And renal functions also I would do, and also with the calcium. So then I have to plan for imaging also for this patient. Ideal setting, MRI would be the best option. So I would plan for MRI spine for this patient.
You would go for any X-rays?
I would take X-rays. If initially I would start with the X-ray, but it might not provide a conclusive, more definitive diagnosis clue. It won't be very specific. But I would do also, considering the resources available, I would consider that as well.
Yeah. So this patient has had an X-ray spine, and that is normal, apart from straight spine. And she has had an MRI also, and that is also normal.
Okay.
But his ESR is high, it's about 80, and the other investigations, blood investigations are normal. Okay. Basically, what biochemical abnormalities usually alert you to go for further investigations?
If the patient with the high ESR, if there are hypercalcemia and anemia, so those features, those biochemical abnormalities are there, I would, it will alert me for further investigations.
Yeah, now his MRI is also normal. If the patient has high ESR, what further imaging you would consider? He has neurological signs, he has a high ESR, but his MRI spine is normal.
Then, sir, I would go for a brain imaging also, I would consider, sir.
For the back pain?
No, sir, that neurological symptoms. That and
is there a benefit
other thing
of
is a
doing
PET scan if available.
Is there a benefit of doing a contrast MRI?
Contrast MRI.
Yeah, of the spine.
Spine.
Yeah. Is there any benefit?
Yes, sir. There could be some demyelination changes which might not be apparent in non-contrast MRI. So I would be able to see those things as well.
Okay, fine. No, what I meant was TB arachnoiditis. You will get a contrast MRI. It's the only investigation that will find it. Anyway, okay. You've given a very, very easy and very common topic. So I would, you of course pass, but when you get a very easy topic, you should perform better, because then, when it's so easy, sometimes I think the performance goes down to a certain extent, because what we expect is a little higher level of, you should take the examiner forward very quickly and coming into the point that we have to investigate this man, and we have to investigate him for a possible cause of where you are keeping a mind in a differential diagnosis, that you find these red flag signs in this gentleman with the back pain. Therefore, you would go for a DD, where basically, in Sri Lankan context, commonly TB and or spinal secondaries, etc. So you should come to that point and say that, these are what I'm thinking, and I have to go for this quickly, and this is what I will do. So that would give you more marks, rather than going in the order you went and talking about, all the, you can summarize things like, you don't have to say that I would check for pain, temperature, and all in detail. You can say that I would look for a focal neurological signs, and I would look for these signs, spinal tenderness, etc., and move forward. Right? Okay, thank you.
Thank you, sir.
Yeah.
Nothing. Yes, I also would give you lower clear pass, right? So you can improve on reasoning.
Thank you.
Yeah. I think we'll conclude the session, but just want to highlight a few points that would help you in the future in facing the Viva. As you know, I think in the prospectus you have given where you will be examined by 2 panels. Each panel will examine the candidate for 20 minutes. So, these are the 4 areas which we discussed already, and it will be a structured format. So, where the standard scenarios will be given to candidates. So, you all are getting the same scenario. Not that one person is asked one scenario and the next person is asked something else. The same format goes through, so it is very fair. Earlier, we could ask different questions from different candidates. So this is structured, same question is asked. And candidates will be tested using predetermined questions, and explained answers will be determined before the examination with some flexibility allowed. Like the examiners will have the question and the answer. So if you give that answer, you cannot be, you should be given the mark. That's why first candidate I said the expected, he gave almost 80% of the expected answer. So then we will have to give 70 marks to him because he gave all the expected answers. So if you don't give the expected answers only, that your marks will come down. The marks will be allocated independently by the examiners. The final mark is 100, as you know. And so in preparation, you see, you should be gathering the skill of explaining. Like you should be able to explain, and you have to keep up with the relevant literature. And there's something called mock viva. I think you should practice a mock viva like this. But I know all the topics you can't practice. So it's your general knowledge, it's your day-to-day practice that is questioned. So you should be able to answer when you come. You won't answer difficult questions like back pain. It's all common clinical problems that is asked, not rare clinical problems. You can prepare likely questions that can come for the Viva, but it's a big range. I don't think you can remember all the questions. So the questions should not be a big surprise, but if one question is, so your questions, it's not a deep surprise. Always the questions are very well formulated and you can understand. It's okay to ask, I'm not clear, sir or madam, because if you're not clear with the question, you should ask rather than giving a answer which is not relevant. If you don't understand the question, ask the examiner for explanations. The examiner will explain. You can say that, sir, I did not understand the question well. Can you explain to me? I mean, that's okay, rather than giving the wrong answer. So you should be prepared. I mean, you should not be worried. You should come in a fresh and know where and when and bring your notes and you can prepare. And before the Viva, the examiners meet and we will decide on the basic minimum that you should give during the Viva. So there's something called calibration, and in the calibration there's a basic minimum that you should perform to pass, and that will not change between the candidates. So it's very fair that you cannot be failed for, if you can say that I perform well, but still I am failed. No, it will never happen because there's a basic minimum decided by the two examiners. Can you fail on the Viva? Yes, theoretically, if you get under 40 in any component of the exam, you can fail, but practically it does not happen. It has happened very rarely. So Viva is there for you to get more marks and improve your overall marks. So this is what is meant. So I said if you have correct answers, it's excellent, over 70. It all depends on how many questions you answer. And it's very well calibrated, so you don't have to worry. Thank you.
Well, that brings us to an end of an interesting session on how to pass MD Viva. Now may I kindly invite all 4 registrars who volunteered for the mock Viva sessions for a photograph, and meanwhile I'll present the certificates of appreciation to the chairpersons and the resource persons today, Professor Shaluka Jayamanna and Professor Shamali Abayagunawardene.
Thank you, everyone.